for decades. I feel like the medical community accepted this really surprisingly dark bargain when treating systemic lupus erythematosus.
Oh, absolutely. The trade-offs were brutal.
Right. Like, to save a patient's kidneys from lupus nephritis, we essentially agreed to just, poison the rest of their body.
Yeah, that's exactly what it was. We relied heavily on these indiscriminate alkylating agents.
Right, like high-dose cyclophosphamide. I mean, and sure, it preserved renal function, but it just left this massive wake of premature ovarian failure, severe infections, and even secondary malignancies.
It was a huge price to pay.
It really was. But the 2024 and 2025 American College of Rheumatology guidelines are fundamentally dismantling that old induction paradigm, which is huge.
It's a completely new era.
Yeah.
We're stepping into targeted multi-agent therapy that actually suppresses the disease while, and this is the key part, actively sparing the patient from all that collateral damage.
Exactly. I'm Dr. Griffin.
I'm Dr. Taylor.
And welcome to today's episode of Evidence at the Bedside.
We are so glad you're tuning in.
Yeah. And hey, if you find these insights helpful for your morning rounds, please consider sharing them with your team. We're on a mission to bridge the gap between complex guidelines and actual bedside care, and we'd love for you to join our clinical community.
So to really appreciate the magnitude of this paradigm shift, I think we have to start at the absolute baseline, right?
Right, the early catch.
Exactly. Capturing the disease before the structural damage in the kidneys becomes irreversible. Because lupus nephritis is, it's notoriously insidious.
It really is. I mean, the kidneys can take massive inflammatory hits without triggering any pain.
Right, no pain, no obvious systemic alarms, and you cannot treat what you haven't properly identified.
Which is why the new ACR guidelines elevate routine screening to a strong recommendation.
Yes. The silent nature of the damage is what makes it so treacherous for us as clinicians.
Yeah, because if you wait for the overt symptoms like, I don't know, gross edema from hypoalbuminemia or this sudden crazy spike in blood pressure.
By then, the nephrons have already been taking heavy fire.
Exactly. The filtration barrier is compromised,
Yeah.
and you've lost critical time. So the directive here is clear, right? You need to screen for proteinuria at least every 6 to 12 months.
Right. And that's in SLE patients who don't even have known kidney disease.
That's routine checking.
Routine checking. But that screening cadence needs to accelerate immediately the moment a patient experiences an extrarenal flare.
Oh, wow. Okay. So like any flare.
Yeah. If you have a patient presenting with an acute polyarthritis flare or, say, a severe cutaneous lupus outbreak, you must immediately look at their urine.
Because the immune system is all connected.
Exactly. It's a systemic network. The circulating autoantibodies and the immune complexes, they don't respect the anatomical boundaries between the joints and the renal glomeruli.
Right, they're just everywhere. Okay, so let's trace that clinical pathway for a second. You run the urinalysis, and it flags positive.
Okay.
You quantify it, and you see proteinuria that's greater than 0.5 grams per gram.
That's the trigger.
Right. This triggers what I think is probably the most crucial good practice mandate in the entire update.
The prompt percutaneous kidney biopsy.
Yes. The prompt biopsy. I mean, treating LN without a biopsy is basically like trying to navigate a ship in the SOG without radar.
Oh, I like that.
Right. Like you might be moving, but you have no idea what you're about to hit.
That analogy holds up perfectly because the clinical presentation, just the proteinuria itself, is completely agnostic to the underlying histopathology.
Right. It doesn't tell you the why.
Exactly. A half gram of protein in the urine could be active destructive cellular proliferation, what we categorize as class 3 or class 4 lupus nephritis.
Right. The really aggressive stuff.
Yeah. But alternatively, it could be pure class V membranous disease.
Which is managed totally differently.
Completely differently. Or, and this is really crucial for the older demographic, the proteinuria might actually just be a mimic.
Oh, right. Like diabetic nephropathy.
Exactly. Or hypertensive nephrosclerosis. The biopsy dictates the entire trajectory of the care.
Which, it raises an interesting methodological point. The guidelines actually acknowledge that the recommendation for a biopsy is technically based on very low quality evidence.
Right, but we have to be careful with that terminology.
Yeah, exactly. It isn't because the biopsy is ineffective or unproven. It's because it would be highly, highly unethical to conduct a randomized controlled trial where we intentionally deprive half the patients of a diagnostic biopsy.
Right. No IRB is ever going to approve that.
Never. So the clinical consensus remains absolute. Get the biopsy.
Always.
But here is the practical friction we hit on the actual wards. Scheduling that percutaneous biopsy, executing it safely, and getting the pathology read, I mean, that can easily take a week or more.
Oh, easily. Sometimes 2.
And during that time, those immune complexes are still just wrecking the podocytes. We're just waiting.
Well, we don't just observe the damage passively while we wait.
Right.
The guidelines actually issue a good practice statement to initiate prompt glucocorticoids for suspected lupus nephritis.
Okay, so this is your bridging therapy.
Exactly. By administering systemic steroids, you rapidly blunt that acute inflammatory cascade.
You're knocking down the capillary permeability.
Right, and suppressing the influx of those inflammatory macrophages. It buys you time while you wait for the definitive tissue diagnosis to map out the long-term strategy.
So the steroids basically act as a temporary dam.
That's a great way to put it.
Yeah. But before we dive into the targeted immunosuppressants, we need to establish the baseline anchor for every single SLE patient.
The bedrock of lupus treatment.
Right. Unless there is a documented severe contraindication like retinal toxicity, hydroxychloroquine is a strong recommendation.
It really is. It has to be on board.
What's the main mechanism there, again, just broadly?
Well, hydroxychloroquine operates by interfering with lysosomal acidification, and it inhibits toll-like receptors.
Right. So it's dampening the innate immune system.
Exactly. Dampening its overactivity, it stabilizes the disease, prevents systemic flares, and notably, this is huge, offers a protective effect against the hypercoagulability that really plagues lupus patients.
Which is a massive morbidity risk. Okay, so the patient is anchored on hydroxychloroquine, the biopsy results finally return, and pathology confirms active proliferative class 3 or class 4 lupus nephritis.
Okay, the aggressive forms.
Historically, this is where we would bring out the heavy artillery, right? The high-dose intravenous cyclophosphamide.
The toxic stuff.
Yeah, but the 2024 and 2025 update pivots aggressively away from that.
It's a huge shift. We are now looking at a conditional recommendation for a triple immunosuppressive regimen up front.
Triple therapy. Okay, break that down for us.
So it consists of pulse intravenous steroids, followed by an oral taper, combined with a mycophenolic acid analog, an MPAA like mycophenolate mofetil, plus a calcineurin inhibitor, or CNI, such as tacrolimus or voclosporin.
Okay, so steroids, MPAA, and a CNI. Let's dig into the pharmacology of why this triple combo is so superior to the old cyclophosphamide regimens. Like, why stack an MPAA with a CNI?
Well, it's really about synergistic targeting rather than just indiscriminate cellular destruction.
Right, cyclophosphamide was basically a carpet bomb.
Exactly. It's an alkylating agent. It cross-links DNA and kills any rapidly dividing cell. That's why it destroys ovarian reserve and bone marrow.
But the MPAA is different.
Very different. Mycophenolic acid analogs specifically inhibit an enzyme called IMPDH, which is crucial for the proliferation of T and B lymphocytes.
Okay.
So you get this profound immunosuppression without all that systemic tissue toxicity.
That makes sense. I understand the MPAA replacing the cyclophosphamide. But what is the specific role of the calcineurin inhibitor in this triad? I mean, are we just doubling down on T-cell suppression?
That is part of it, yes. But the true brilliance of adding a CNI lies in its non-immunological effects in the kidney itself.
Wait, really? It acts mechanically?
Yes. Calcineurin inhibitors have a direct, rapid stabilizing effect on the podocytes.
Those are the specialized cells wrapping around the capillaries of the glomerulus.
Exactly. In lupus nephritis, the inflammation disrupts the actin cytoskeleton of those podocytes, causing them to efface or flatten out.
And that's what allows massive amounts of protein to just leak into the urine.
You got it. The CNIs actually mechanically stabilize that actin cytoskeleton.
Oh, wow.
Yeah, which drops the proteinuria dramatically and quickly, while the MPAA works in the background on the broader long-term suppression of the autoantibodies.
So the CNI is structurally reinforcing the renal filter, while the MPAA shuts down the immune factory.
That's a perfect summary.
That makes complete mechanical sense. But does this triple therapy approach universally apply to all biopsy results? Take pure class V, for example.
Yeah.
Membranous lupus nephritis.
Right, the non-proliferative class.
Yeah, it lacks that aggressive proliferative inflammation seen in classes 3 and 4, but it still causes really heavy proteinuria.
The guidelines are highly nuanced here. They stratify the treatment based on the sheer volume of protein loss.
So it depends on the numbers.
Yes. If a pure class V patient is spilling 1 gram per gram or more of protein, the recommendation aligns with class 3 and 4.
Meaning you go with the triple therapy.
Exactly. You utilize the triple therapy of steroids, MPAA, and a CNI. The heavy proteinuria indicates severe podocyte disruption, so you need that CNI stabilization.
Okay, but what if it's lower?
If their proteinuria is less than 1 gram per gram, dual therapy, meaning steroids, alongside a single immunosuppressant is conditionally recommended.
Got it. So you really scale the regimen to the mechanical failure of the filtration barrier.
Precisely.
All right, so let's address probably the most highly debated aspect of this new induction paradigm, the steroid taper.
Oh, yes. The great taper debate.
Right. So the initial pulse IV steroids are standard, but the oral tapering schedule has been drastically accelerated. The guidelines now push a strict less is more philosophy.
Very strict.
They are targeting a reduction to 5 milligrams a day or less of prednisone by month 6. I mean, I look at that and I hear the collective anxiety of 1,000 older rheumatologists.
That makes a lot of people nervous.
How do we justify to our colleagues and to patients pulling back the steroids so quickly? Aren't we just inviting a massive rebound flare?
Well, it requires a complete reframing of how we calculate clinical risk.
How so?
For decades, we viewed glucocorticoid toxicity, the avascular necrosis of the hips, the severe osteoporosis, early onset cataracts, cardiovascular disease.
Basically falling apart.
Right. We viewed all of that as unavoidable collateral damage in the fight to save the kidneys.
Just the cost of doing business.
Exactly. But the long-term data now clearly demonstrates that cumulative steroid exposure drives a staggering amount of irreversible organ damage.
So the cure was almost as bad as the disease.
The therapy was destroying the patient's quality of life just as effectively as the lupus was.
I see the logic. Because by utilizing the highly effective combination of an MPAA and a CNI up front, we established this really robust immunosuppressive net.
Exactly. The foundation is strong.
The steroids are just there to knock down the initial acute wave of inflammation.
Right. And by the time we taper the prednisone down to 5 milligrams at the 6-month mark, the MPAA and CNI are fully active and holding the line.
Which allows us to withdraw the steroids before they cause permanent metabolic and structural damage.
That is the exact physiological strategy. We are aiming for the ultimate long-term clinical objective, which is a sustained complete renal response, or CRR.
CRR. And how long do we keep them on the maintenance meds once they hit that response?
Well, while the literature backing the optimal duration of maintenance therapy is technically considered low-quality evidence, the clinical consensus is firm.
Which is?
To maintain that CRR and prevent relapse, the guidelines conditionally recommend continuing the non-steroid immunosuppressive therapy for a total of 3 to 5 years after the response is initially achieved.
Wow. 3 to 5 years of complex daily medication.
It's a long road.
Which brings us to the harsh reality of outpatient management. What is our framework when a patient simply isn't responding?
The refractory cases.
Right. The proteinuria remains high, the GFR is stagnating, and we are just staring down the barrel of progressive renal failure. My first instinct, and I think the instinct of many clinicians, is to assume the disease is biologically refractory and immediately escalate to heavier investigational biologic agents.
And the guidelines anticipate that exact reflex. They explicitly install a good practice speed bump right there.
A speed bump?
Yes. Before you even consider labeling a patient's disease as refractory, you must aggressively assess medication adherence.
Oh, absolutely.
Because non-response is overwhelmingly driven by insufficient drug exposure, not biological resistance.
Which honestly is entirely understandable from the patient's perspective.
Right.
I mean, we are prescribing mycophenolic acid, which is notorious for causing severe gastrointestinal distress.
Nausea, cramping, terrible diarrhea.
Right. If a patient is skipping their doses just to physically get through their workday, writing them a prescription for an even more complex, expensive biologic isn't going to solve the problem.
It will only complicate it. The adherence check is mandatory.
Okay, so let's assume we do the check. We confirm strict adherence, and the patient still fails to achieve at least a partial renal response by the 6 to 12-month mark.
Then we initiate the escalation pathway.
How does that look?
Well, if they started on dual therapy, we escalate them to the triple therapy we discussed.
Makes sense.
If they were already on triple therapy and fail, which the guidelines formally define as true refractory disease after failing 2 standard courses, then we move to conditional recommendations for intensive escalation.
And what does that intensive escalation look like mechanically?
It typically involves transitioning to an anti-CD20 monoclonal antibody.
Like rituximab.
Exactly.
Yeah.
To aggressively deplete the B-cell populations that are driving the autoantibody production.
Okay. Are there other options?
Alternatively, it might involve a multi-agent regimen utilizing 3 non-glucocorticoid immunosuppressives. And honestly, this is also the stage where referral for clinical trials and investigational therapies becomes highly relevant.
we really need to contextualize this escalation for our special populations too, because the guardrails change significantly.
Oh, absolutely.
Let's look at childhood onset SLE, or CSLE. Pediatric rheumatologists are walking a massive tightrope here.
It's incredibly challenging.
The guidelines issue a stark warning regarding prolonged steroid exposure in children. I mean, it will suppress growth hormone release and directly fuse the epiphyseal plates.
Which permanently stunts their growth velocity.
Right. It also heavily delays pubertal onset.
Which makes that accelerated steroid taper we just discussed even more critical in pediatrics.
We have to get them off the steroids.
We do. Furthermore, the guidelines highlight a highly vulnerable window for these younger patients.
The transition phase.
Yes, the transition from pediatric to adult care. A structured, intentional handoff to adult rheumatology is an actual good practice statement.
Because that transition period is historically where medication adherence just plummets.
Exactly. They go to college, they lose their parental safety net, and it leads to catastrophic flares and rapid progression to renal failure.
Conversely, managing our older adult population presents a completely different pharmacokinetic challenge.
Oh, completely.
Right, because as humans age, we naturally lose functioning nephrons, leading to an age-related decline in the glomerular filtration rate.
The GFR drops naturally.
Yeah, and if an older patient is on a complex regimen of renally cleared medications, and we fail to continuously adjust for that declining GFR, the drugs will just accumulate.
You inadvertently push them right into toxic ranges.
Exactly, exacerbating polypharmacy risks.
This careful balancing act, adjusting for adherence, managing toxicities, and navigating these special populations is what makes lupus nephritis so difficult to manage.
It's an art and a science.
It is. And despite our most aggressive triple therapies and meticulous dose adjustments, a subset of patients will still suffer progressive nephron loss and reach end-stage kidney disease, or ESKD.
Which is devastating.
When the filtration barrier fails completely, the entire treatment paradigm has to pivot.
Right, to renal replacement therapy. It is the outcome we literally spend years trying to avoid. But the guidelines actually provide a rare, definitive directive for when it happens.
They do. For lupus nephritis patients reaching ESKD, there is a high-quality evidence, strong recommendation favoring kidney transplantation over chronic dialysis.
Wait, high-quality evidence? In the world of rheumatology guidelines, that is incredibly rare.
It's almost unheard of.
Why is the data so overwhelmingly clear on this point?
Because the physiological toll of dialysis is just catastrophic for someone with a pre-existing systemic autoimmune disease.
That makes sense.
Dialysis introduces massive cardiovascular stress, extreme fluid shifts, and a very high infectious burden from the vascular access points.
And all that is amplified by the underlying SLE.
Exactly. Transplantation, by contrast, restores the physiological filtration barrier and offers a drastically higher long-term survival rate. The evidence is so strong that the guidelines conditionally recommend preemptive kidney transplantation.
Just to clarify the mechanics of that for our listeners, preemptive means we are listing and transplanting the patient before they ever even require a dialysis catheter.
Correct. When a patient's estimated GFR drops to 15, we should actively transition them toward transplant evaluation.
Wow, okay.
And there is a vital shift in the immunological thinking here. You can conditionally proceed with that transplant even if the patient has not achieved complete serologic remission of their lupus.
As long as no other major organs are acutely failing.
Yes.
See, that used to be a hard stop. The old school of thought was that if the systemic lupus was still active, the circulating autoantibodies would just immediately recognize the new kidney and destroy it.
Right. We are terrified of that. But the reality is that the heavy immunosuppression required to prevent organ rejection, the high-dose tacrolimus and mycophenolate, it simultaneously treats the underlying lupus.
Oh, right. The transplant meds keeps the autoimmune disease heavily suppressed anyway.
Exactly. It allows us to get these patients off the transplant wait list much faster. But it is crucial to recognize that a new kidney does not cure systemic lupus erythematosus.
Right. The disease is still there.
There is a strong recommendation for continuous rheumatology follow-up post-transplant or while on dialysis, because the underlying autoreactivity remains.
The systemic threat never fully vanishes. Well, we have covered the entire clinical continuum today. Let's synthesize these 2024-2025 ACR guidelines by tracing the ideal trajectory of a theoretical patient, and we'll just embed our key takeaways along their journey in a rapid-fire style.
I love that. Let's do it.
All right, pearl number 1. On day 1 of an SLE diagnosis, regardless of renal involvement, we anchor the patient with hydroxychloroquine. It remains the universal baseline.
Pearl number 2. As we monitor them, we screen their urine for proteinuria every 6 to 12 months and immediately during any joint or skin flare.
Pearl number 3. At month 18, say the screen comes back positive. We don't guess the pathology, we get the tissue. Prompt kidney biopsy is essential to confirm the disease class and rule out mimics. Don't fly blind.
Pearl 4. The biopsy confirms active class 3 or 5E disease. We initiate the new standard of care, triple therapy. Steroids, plus an MPAA, plus a calcineurin inhibitor.
Pearl 5. By month 6 of treatment, we relentlessly pursue the less is more steroid taper, dropping the prednisone to 5 milligrams a day or less to prevent cumulative organ damage.
Pearl 6. If we reach month 12 and there's no clinical response, we stop and assess medication adherence before we ever escalate therapy for refractory disease.
And Pearl 7. Looking years down the line, if the disease ultimately progresses to end-stage kidney disease, we push aggressively for preemptive kidney transplantation over dialysis.
That trajectory really highlights exactly how deeply intertwined these organ systems are.
Yeah, lupus nephritis definitely cannot be managed in a silo.
Not at all. The rheumatologist cannot execute this alone, and the nephrologist cannot execute this alone.
It requires really tight, multidisciplinary collaboration.
Yeah.
Especially when you're navigating things like the severe thrombosis risks associated with heavy proteinuria.
Yes, getting the anticoagulation right for those patients with low serum albumin is tricky. And of course, coordinating the exact timing of a preemptive transplant.
Right. The complexity of SLE just demands a unified clinical front.
It really does. And we want to help you build that front. If you found this discussion valuable, please subscribe to the show. We are continually unpacking these evolving guidelines to help you elevate the standard of care for your SLE patients.
Absolutely. Please like, share, and subscribe to Evidence at the Bedside. But before we sign off, I want to leave you with a thought that extends a bit beyond these current guidelines.
Oh, interesting.
We spend years meticulously calibrating these complex regimens to suppress a rogue immune system right now. But what if the future isn't about suppression at all?
What do you mean?
What if we could simply delete the aberrant immune memory? With the early, staggering data emerging on CD19 CRT cell therapy in refractory lupus, essentially wiping out the autoreactive B cells and letting the immune system reboot from scratch, we might be looking at the last decade where we merely manage lupus nephritis instead of actually curing it.
Now that is an exciting thought.
It really is. Until next time, keep your evidence sharp and your clinical index of suspicion even sharper.